community outreach workers can care for members with complex needs. And we are going to be recording the session. So we have a few housekeeping items just to remind you all. As I mentioned, we're going to be recording this session, and slides and recordings will be posted on the CIN website within a week. We will also send out the recording to anyone who registered for this call by email. And for today, because we have so much content, we have quite a number of slides to get through, we ask that you use the chat function to ask any questions you might have, and you're welcome to do that throughout the presentation, but our presenter for today is probably not going to get to your questions or answer them until more towards the end of the call. If you have logistical questions, please chat to the host. If you have questions for the presenter, you're going to chat to all, or there's also a choice where you can chat to the presenter. And so with the next slide, I'm going to be introducing you to our speaker today. Her name is Rebecca Ramsey, and Rebecca has developed and implemented CareOregon's Community Care Program, which deploys specially trained non-medical outreach workers anchored to primary care practices to partner with high-cost patients who suffer from multiple chronic medical conditions overlaid with mental illness, trauma, and/or addiction. Rebecca has been with CareOregon for 7 years, and in that time she's also worked on team-based case management programs and complex chronic disease programs. So she's a real asset for the call today, and we're happy to have her. Rebecca, I'm going to pass the ball to you now.
Wonderful. Well, welcome everyone, and thanks for joining us today. I'm going to speak about a new program, and I don't know when I get to stop calling it a new program, but it's been in existence for about 18 months, and we began the planning for it about 2 years ago. And this is a program that initially was funded entirely by CareOregon, and CareOregon is a publicly financed health plan for Medicaid and dually eligible citizens in the state of Oregon. So we're a Medicaid managed care organization. We have around 180,000 members. We're not-for-profit. We have a fully contracted network currently with about 50% or more of our members being seen in safety net provider practices, community health centers. And we contract with all the major metro and rural hospitals. So we do have membership across the state, but about 80% of our population does live in the metro area, the 3 counties surrounding Portland. And my history with CareOregon is that I began building population-based programs really back in 2005, and then started working really closely with our patient-centered medical home work in our state for Medicaid, primarily Medicaid recipients. We, as an organization, and myself as an individual, have participated with IHI in their Triple Aim initiative since the very beginning. We were one of the prototyping sites, and so I'm now faculty for IHI on that initiative. But what I really want to talk about today is what CareOregon and our community has learned about the needs of the most expensive, costliest populations within the Medicaid and dual eligible enterprise population. And so this is just a little bit of background. Some of you may have seen I believe this came from the Commonwealth, but you may have seen other versions of this. And basically what we're talking about is the top 5 to 10% of the population that is spending or is using 50 to 70% of the resources of the healthcare dollars. So our goal with the program I'm going to talk to you about is really to target that top 5 to 10% of the population that we provide services to. The other thing that's important to understand is that there's a lot of variability in that top 5 to 10%. This is a slide that came from AHRQ, and what you're seeing on the left axis is basically what percentage of the population that was high cost in 2008 continued to be high cost in 2009. And I want to draw your attention in particular, just because this is a lot of information, so I want to just focus on those patients that were in the top 10% in 2008 in terms of cost. Only 44% of them continued to be in the top 10% in the following year. And so what that means is that roughly half of those individuals in year 2, in the following year, did not continue on that trajectory of healthcare expenditure for a variety of reasons. And so part of the challenge with building programs for a high-cost population is that you have to really learn and pay attention to identifying that population that is persistently high cost, because you don't want to spend valuable resources on a population that without any special attention would have regressed to the mean or become not high cost in the following year. So it's really looking at those individuals that have a myriad of comorbidities and a pattern, a trajectory of healthcare expenditure that isn't as variable or volatile. So in terms of our population, this is a 2009 slide, but the patterns hold true. This is state of Oregon Medicaid data, and it's basically looking at where the state Medicaid budget is spent in terms of categories in the healthcare expenditure budget. So in other words, what we're seeing here is that over 40%, 43% of the total Medicaid budget is spent in hospital and ER charges. So that's the sort of golden opportunity. That's not to say that there aren't a lot of opportunities in other service arenas, but the program we're talking about is really targeting those individuals that are in the hospital and the ED a lot, and most importantly, for potentially avoidable reasons. Now, the other thing that's important to understand is that what is driving those high-cost expenditures. And so we've done a lot of different looks using a lot of different slices of the data and ultimately working closely with patients to really uncover the root causes of high utilization. But what's interesting and somewhat surprising about this prevalence data is that, and I apologize, this is a little bit of a kindergarten pie chart because we don't have actual percentages, and these are not mutually exclusive. But what this slide tells us is essentially that the prevalence of mental illness, chemical dependency, ADD, and trauma, or post-traumatic stress disorder, is actually higher in this population than the prevalence of the more traditional chronic medical conditions that many of us have been working to provide better care for. And so if we're going to make a dent in the expenditures of this population, we cannot ignore that there are these comorbidities that don't necessarily aren't necessarily those conditions for which a lot of us as medical professionals were uniquely trained to manage and to treat. Another look at that is when we take CareOregon claims data and we use diagnostic markers to categorize individuals based on chronic disease, we can see that if you add the comorbidity of mental illness or substance use, both the utilization in the ED and the hospital and the cost over a 12-month period of time for those individuals doubles or triples. And so again, this is not new information for most of you. It's just that when you see it visually and you actually go into the actual dollar and utilization admission data, it is very validating of what we see in practice, and it puts sort of a numerical value on the struggles and challenges that we all face when individuals have multiple comorbidities, particularly those in the mental health and addictions realm. So this is just looking at adults with diabetes and adults with congestive heart failure and adding a comorbidity of substance use or complex mental health diagnosis. In our claims data, complex mental health pulls out diagnoses for bipolar, schizophrenia, major depression, schizoaffective, so the sort of fairly traditional mental health diagnoses, severe mental health diagnoses. So when we started piloting our program, our goal was to partner with the safety net practices that we had been working with for many years on building more robust primary care homes and placing what we, at the time, very initially couldn't define super clearly but knew was a new workforce into their primary care setting. The health plan would, the idea was the health plan would pay for the salary of the new workforce professional and would provide infrastructure, data support, and supervision, but would actually deploy these individuals into the primary care setting to then work with the primary care setting as the hub, but doing most of their work out in the community where people live, where these clients live, be it their homes, group homes, shelters, et cetera. And so we had to identify some target criteria. In other words, we had to answer the question, who are we focusing on with this program? And so because we're a health plan, we started with claims data, but we've gone much beyond that now. But we started with claims data, and we created 3 population segments based on inpatient and ED utilization over the past 12 months. So you'll see on the left in the population segment column those 3 strata. The first is patients that have had no inpatient admissions but 6 or more ED visits in the last 12 months. The second strata is patients that have had 1 non-obstetric related inpatient admission and up to 5 ED visits. So this is not a program that's serving high-risk pregnancies. As you can imagine, that's a different intervention and a different skill set. So we took all of the obstetric-related admissions out of our data set. And we're also just looking at adults, 18 and above. The third strata are those individuals that have had 2 or more non-obstetric-related inpatient admissions or 1 and over 6 ED visits. And then you can see, as you go across the rows, the number of members in a particular safety net practice, primary care practice. You can see at the top, this is Multnomah County Health Department, Northeast Clinic population. You can see how many individuals met that criteria, the percent of the total membership that those strata make up. So it totals about 10% of the membership, a little over 200 members. And then you can see across the top the average total paid cost, the percentage of the cost that made up. So that 32%, 14%, and 5% equals 51% of the total cost of the total large enterprise population of CareOregon members seen in this clinic. And then the number of ED visits and inpatient admissions. So that was our initial target population. And so we identified clinics that had at least 100 to 125 members that met this criteria in their clinic, and we made a decision that if they had 100 to 125, that would warrant probably working with them closely and developing this pilot. Now, it turns out that as we got rolling, claims data lags, as most of you know, and it's not a great case finding tool. It's a great how big is the bread basket type of a question, response. So you can say, how big is this population in your particular clinic? But to use this kind of data to identify people in real time is challenging because it's 3 to 4 months old. People's situations have changed. Some of them have dropped off the plan. Some of them have moved out of area. And some of them have resolved their acute issues. So we don't use this for case finding. Instead, we rely on real-time event notification reports from hospitals and from emergency departments, and we rely on provider referrals. The more that we work with a clinic, the more that the leadership and the primary care providers in that clinic understand the appropriate client to refer. So to put a face with and a story with these numbers, I just want to tell you about one of the first clients that we served with this program. This is not his real name and this is not his real photo, but he was a 66-year-old African-American male, and he had a whole host of both biopsychosocial risk factors and medical conditions that he was struggling with, including a previous history of addiction to IV drugs and alcohol, a very mild developmental disorder, and was intermittently homeless, also had schizoaffective disorder. This is, a picture that is not uncommon among the population that we're serving with this program. And we identified him because he was admitted to the hospital for almost a month for acute complications of his chronic heart failure, and had a previous 25-day admission 5 months earlier. Now, for those of you that are up on your statistics for length of stay, et cetera, a typical chronic heart failure admission is, in our environment in the Pacific Northwest, is about 4.5 days for one admission in terms of length of stay. So this is this individual is a huge outlier. And that's a very, very expensive admission. And as you can see, given his story and the kind of conditions and situation he's dealing with, it's not surprising that it was difficult to discharge him. Now, these are labels that you might find in a chart or diagnoses codes that you might find in claims, but it doesn't really tell you who William is. And I'll just give you a little snippet. William, about a year before we started working with him, his brother died, and he had been his caretaker, and he had also been living with his brother. And things started to unravel tremendously for William when his brother died. He actually became homeless. He did not have anyone to help him with his problem-solving skills and medication issues. He was so mildly impaired that people didn't pick up on it right away. And it wasn't until our outreach worker really got to know him that she was able to start putting some pieces back together, advocating for him, getting him on housing lists, helping him problem solve, identifying other relatives to work with or to stay with, and friends. A whole host of interventions occurred with William. So that's just a little bit of a snippet of a story, and I'm happy to talk more about that case in the question and answer section. But I want to talk a little bit more about the program structure. So in my work with IHI, we have identified basically 3 models that we see across the country that are primary care-based programs for high-risk, high-cost patients. There are programs that you might have heard referred to as ambulatory ICUs, which is really a very high-cost intensive model that is almost like reimagining the primary care office into a different kind of practice that specializes in very, very high-risk patients. And often it's expensive because you add a bunch of, ancillary services that meet the needs of this very high-cost population. There's also a few models where they take existing primary care practices and just try and retrain the care teams and reassemble people that have always worked in these clinics with new roles. And a really good example of this would be, if any of you are familiar with the work at South Central Foundation up in Anchorage, they were the model for our primary care renewal program, where we started, kind of before the medical home trend became really popular and really focused and somewhat incentivized, and we learned from them and built our safety net primary care model after theirs. And then the third model that is emerging is the one that we're piloting, and it's a model that enhances really good primary care, and that's instrumental, that phrase, really good primary care. This program doesn't work if you don't have a robust team-based medical home model in place. But it enhances that really good primary care with a new skill set that I refer to as a non-traditional healthcare worker that takes their assistance, Their hub is the primary care clinic, but they take their assistants into the community and work in the community with these individuals. So here is part of our team. This photo was taken several months ago, and we actually have six more staff that are not represented here. But again, this is the group of individuals that I will be talking about. They are embedded in across about 12 clinics because we have hired additional staff. Primarily, they're working in primary care, but there are two that are actually piloting a model in specialty practices. So we have Heather Stocklin, who's down in the lower left, and her friend Peggy, who's missing a face because she was out of town that day. So we had to get really creative. So Heather is a respiratory therapist, and she's working in a pulmonary practice. And Peggy is a nurse, and she's working in a high-risk gastroenterology practice with high-risk liver patients. And so their skill sets are different than the community outreach workers because we hypothesized that because it was a specialty practice, we would need a bit more of a clinical skill set. So what we do is we train them on all of the community engagement, home visiting, safety protocols, motivational interviewing, trauma-informed care, all of the sort of basic competencies and skill sets that we want all of our outreach workers to have. We overtrain the clinical staff because they may not have had as much exposure to those as some of our other staff that we hire. Again, they're hired for their engagement skills, compassion, non-judgmental attitude, and outreach experience. I'm going to go into another slide that describes their competencies more clearly. I will tell you that we do not require any particular licensure other than the two that I described, the nurse and the respiratory therapist. We are hiring for interpersonal skill set versus types of education, certification, or licensure. Because the focus is on the social determinants that drive high-cost utilization, therefore, we need to match that need with the appropriate skill set, which is not a technical medical skill set. As I've suggested, the outreach worker is intentionally incorporated as part of the practice team, but also, and this is really, I believe, key to our success, they are also identify with a larger community of practice. So because we are running this program centrally, and it's the health plan, and now with healthcare reform in the state of Oregon, it's actually our coordinated care organization that is really managing and running this program as a community asset to the provider practices that partner with us. And so we bring the outreach workers together on a weekly basis and do a lot of training, coaching. We have a huddle every Tuesday morning for an hour where they present complicated cases, and a team of us, and it's mostly their peers, help them problem solve through some of the most difficult, challenging cases, and they get a lot of peer support from us at the program level. We also have supervision centrally, but our supervisors go into the clinics and supervise in those clinic settings, so they get to know the practice environment and the clinical champions in the clinics. But they're all hired and paid for and managed centrally. The documentation occurs within the practice's electronic medical record, but there's also a registry system that CareOregon has developed that allows them to track their populations they're serving in a very efficient way. We can pull productivity and caseload metrics out of that registry in a much more readily than we could pulling it out of the EMR. So we keep them from double documenting by basically separating what they document in each system. So in the EMR, they're just documenting their narrative notes so that the team that's managing this patient understands what's going on from a community outreach worker perspective. They can also, inbox message providers and get questions answered, et cetera. they work pretty closely with pharmacists as well. We have a lot of pharmacists in these clinics who are it's a team approach. So they're really, actually, some of the pharmacists even go out on home visits with the outreach workers and do medication reconciliation and medication teaching. In the community care registry, it's literally just drop-down menu type documentation, but it allows us to do program evaluation. They track travel time, they track touches, they track very specific tasks that they're doing with clients so that we can start to look at what are the most common needs and tasks that are making up this programmatic intervention. And then the other thing is that this is a voluntary program. So we do not use any form of coercion or anything to convince somebody to participate other than walking alongside them, planting seeds, and waiting for them to be ready. So we've had to do a lot of communication with providers about this because they don't understand why we don't always engage everybody, and it's really it's based on the readiness of the client. With our community outreach workers' engagement skills, they do a really, really good job, and most of the clients that they approach do end up engaging. It just may take a couple of months. So what are the secret ingredients? I boiled it down to 4, but it's hard to articulate how different and powerful we are finding this intervention to be for this particular population. Transparency is really, really paramount. We do not hold anything back, and so we've had providers actually say to us, I don't want you to tell the client this, but I want you to X, Y, Z. And our approach has been we cannot build trust and rapport with these clients, many of whom have extensive trauma histories and so already are very distrustful, if we are not fully transparent. And so that's just a philosophical tenet, is that we are fully transparent with clients. And that leads to the ability to develop trust with a pretty vulnerable population. I think that in many ways, the fact that our outreach workers are not traditional medical professionals helps to reduce the hierarchy in the relationship and makes it safer for clients to reveal some of the pretty heart-wrenching barriers that they're facing. Time is huge. So our outreach workers have low caseloads. The expectation is that they have, at any given time, 20 engaged clients and no more, and then 10 additional clients that are in some phase of engagement, so doing assessment or outreach, or maybe in a maintenance phase where they're just about ready to graduate. So because of that, they really do have much more time to spend, and they're doing most of their spending of that time out in the community, meeting people in their homes, in shelters, under bridges, at parks, in coffee shops. They also have a very modest budget that they can spend on things that are not typically covered by the Medicaid benefit, including cups of coffee, sleeping bags, shoes, calendars, you name it, anything that, I mean, you may have heard the John Kitzhaber air conditioner story keeps going around in the national news. So that was one of our clients a couple years ago, where we actually bought them an air conditioner because she had pulmonary and heart failure symptoms and was in a stuffy apartment. And then finally, tailoring to the client. So one of the real philosophical tenets is that because we're not currently in a fee-for-service environment with this workforce, they are health plan and grant funded currently. They are learning that because they don't have payment-related documentation standards that they have to follow, they can actually go into a relationship with a client that is truly client-centered. They don't have particular check boxes and billing requirements that they have to fill out, and they don't have a particular time period that they have to keep to when they're working with a client. And it is hugely beneficial to really staying on the agenda of the client, which is what we believe helps a lot of these clients turn the corner in terms of becoming more embedded and engaged in their health. That will obviously change when we need to build more of a sustainable payment model, and so I feel like one of my roles is to continue to beat the drum that we need to build a system that does not require them to strip away the client's agenda by driving it through payment-related documentation and regulations. Here is a litany of, not a fully exhaustive list of particular tasks and interventions, but it gives you a sense of the kinds of things that our outreach workers are doing with these clients. Lots of motivational interviewing and engagement work, client advocacy within and among multiple systems, role modeling, both actually with the clients and to some extent with the primary care teams. A lot of what we're realizing and actually hearing about from providers is that now that they're understanding some of the issues that are facing these complex clients, they're actually, the primary care providers and the teams are thinking very differently about how to work with their clients. And they are learning things about their lives that they would never have known without this deep relationship from the outreach worker, bringing back that information. Assistance in navigating the healthcare system is huge. So a lot of care coordination, a lot of health literacy education and self-management skill development. You know, cognitive limitations are definitely common, whether they're organic, whether they're due to substance use, or otherwise. We do find that that's quite common. And again, it's the kind of limitation that goes unnoticed until you really get to know someone. And then again, problem solving related to living in poverty with multiple health issues. This one here, providing opportunities to identify as something other than a patient. I added that recently after hearing multiple case presentations where the corner was turned as a result of helping to engage the client in something other than thinking about all the things that were wrong with their life and with their health or lack of health. And so, you know, when you hear the stories about these clients, you can, it's so easy to imagine that they just they identify themselves as sick, ill, and of needing care, whether it be, you know, calling the ambulance and going to the ER, or you know, any litany of, you know, calling the provider for things that maybe don't need to be dealt with in the clinic. And so it becomes almost a habit, a pattern of being, and a way of validating who they are. And so what we're trying to do is actually disrupt that and provide alternatives. And so again, if I had more time, I would give you a lot of examples of where this has come into play. Deep listening, acknowledgement, and respect, providing opportunities to experience success and feel confident. What makes a successful outreach worker? Well, first and foremost, you need to understand the needs of your population, because you can't develop the correct workforce just based on this presentation, because what I have learned is that each community and each high-cost population is not the same. They're all unique. And we actually visited 2 programs, one in Boston and one in Camden, New Jersey, that has been featured quite a bit, the Camden Healthcare Coalition, to get ideas about this pilot program. And we took a ton of learning from those programs, but ultimately what was driving high-cost utilization in each of those communities was different than what's driving high-cost utilization in our environment. And so we don't have the same skill set or workforce as they do in those two other programs. In Boston, they actually have hired a very clinical skill set of nurses and to some degree nurse practitioners because they have really poor primary care access. And so these individuals are suffering from poverty and multiple comorbidities and can't get a primary care appointment for 4 to 6 weeks. And so they literally need medical SWAT teams to go and help serve this population, whereas our access is actually pretty good for Medicaid adults. So our teams look different. We match the skill set and workforce to the needs of the population and the environment that we're in regionally. For our population, though, we need in our workforce a trained workforce. So we are not hiring lay individuals. They're not medical professionals for the most part, but they are experienced. So we require at least 2 to 3 years of community outreach experience working with high-risk, vulnerable populations. They don't have to be exactly the same population. Some of our outreach workers have worked with high-risk kids and families, but they've all done home visits for at least 2 years in our community. They have to have comfort and experience with mental health conditions, addiction, substance abuse, poverty, and trauma to some degree. Excellent interpersonal skills, professional boundaries, and enough confidence to communicate and advocate with medical professionals. Compassion, I've talked about a lot of these. So I'm going to move ahead in the interest of time. The structure at CareOregon is that I'm the director of the program. I have a program manager that reports to me who has a community mental health background. We have a data coordinator and an evaluation scientist that is helping us develop our evaluation plan and certainly will be helping us with calculating our return on investment as we start to think about a sustainability and payment model for this program. We also have 2 supervisors that report up to the program manager, and they're both licensed clinical social workers, and a triage coordinator that helps us manage the input of real-time event notification reports to help case find appropriate individuals. And then you can see that we have almost 16 community outreach workers across 13 clinics and still growing. This is a complicated slide that really just visually depicts that we have statuses that people move through, clients move through, from referral to assessment to outreach to engagement to maintenance and to completion. And these are all tracked within our registry system. This gives you a sense of the caseloads. We fluctuate between 18 and 20 is our target for engaged. We still have a number of outreach workers that have only been with us for a couple of months because we're growing very quickly. So their caseloads, it takes about 6 months to ramp up to a full caseload with all the training and orientation required. Again, a lot of workforce development. Although we're hiring a fairly experienced staff, we do require that they get a very in-depth motivational interviewing workshop and follow-up trainings. Trauma-informed care is huge. We could talk for a whole nother hour about what that is and why that's important. A lot of addiction and treatment modality trainings from our community chemical dependency colleagues. Chronic disease fundamentals, training on severe mental health conditions and their treatment. Information from our developmental disabilities, health and human services division. And then we're starting to bring in, we just recently had somebody from hospice come in and talk about bereavement and death and dying, because not surprisingly we are losing a number of clients while they're enrolled in our program. And then to finish up, I just want to talk a little bit about what we look at in terms of success markers. Let's go back to William for a second. Now, he has graduated from the program, and this is just a run chart of his healthcare costs over the course of the last couple of years. The red line indicates when we became involved with him, and you can see that his healthcare costs are quite a bit lower. Now, there's no way for us to know if this was a direct result of what we did, but we're looking at trends. There's also no way to know if this would have happened without our help. But what's interesting is if you have claims data and you can look at what was driving costs before and after, this is not supposed to be an eye test, I apologize. The red indicates healthcare costs as a result of hospitalizations, and the other colors are things like referral services, primary care services, pharmacy is blue, green is other ancillary services. So you can see that there's a redistribution of what we are spending to care for William. And in a future version of this slide, I will be adding in the cost of the outreach worker, but I can tell you that I did some calculations, and it takes very little to more than pay for the salary of an outreach worker, which is about $41,000 per year. And if you spread that out across a caseload of 60 individuals, which is what their target is for managing over the course of a year, this becomes a very inexpensive program, which is why it's being looked at nationally as an alternative to the more expensive AICU models out there. I'm almost done here. We did do an interim evaluation with a very small cohort of patients in January. We're about to do another one, which will be much, much more robust because we'll have a much bigger denominator because we have a lot more outreach workers. But what we did was we split the clients up into, and you can see there it's only a little over 40 clients that we were able to evaluate, because we had to have clients that had enough exposure to the program that it made sense to evaluate them. And we put them into four groups. First group was thumbs up. These clients actively engaged and actually graduated. The second group were those that engaged for a time but stopped participating. They're sort of like the koala bear that's a little hesitant. The third group they said they would participate, but then we could never really get them to participate fully, or they actively declined. And then the fourth group were those that at the time of the evaluation were still currently enrolled, so they didn't have quite as long of an exposure to the intervention. And what we looked at was ED visits per person prior to the intervention and post. And we adjusted for member months. So the average months per person prior to enrollment was around 10 months, and after enrollment was around 8. And then we averaged it. So we adjusted for that. And you can see here that in group 1, the ones that completed, we had a 32% reduction. Again, this is only 11 clients, so you can't publish. This is not, this is just process improvement trending data. But we're seeing reductions in all 3 groups except the group that didn't participate. We looked at inpatient admits, and again, we saw a reduction except in the group that didn't participate and the group that was still receiving a dose of the intervention. That was about equivalent, pre and post. And then we added ED visits and inpatient admits together and created an index of acute events per person per year. So this is just putting them together and counting admits for ED and hospital together. And again, similar pattern. And then we looked at PCP visits per person per year, and this is a little bit surprising. We actually saw decreases in PCP visits per year for those that participated in the program, and we actually thought we might see an increase. For cost reasons, this is fabulous, and I would say for primary care providers who feel burdened by this very high cost population, this is also a very good thing. The outreach workers will say that the reason this happens is because they're getting their needs met in other ways, and that they were, looking for love in all the wrong places, so to speak, prior to the program. So here's just the total, 46 clients. We're seeing decreases in the right place, except for the inpatient admits, and we think that part of that, although we'll be able to look at this again in the summer, may be an artifact of the 13 people included in the analysis that only had a few months of exposure to the intervention. We're also doing health status and care experience surveys that are mailed so that we can get a more rounded triple aim evaluation completed. And qualitative interviews that we actually just got a report back from our interview team with some really fascinating information about how the staff are experiencing the program and how the clients are experiencing the program. Very, very positive. So I'm going to end there. We have 15 more minutes for questions. I don't see anything. Let's see. I do see one question. What is the application vendor used to track the community of practice care and then the population health analysis? I don't think I'm understanding that question. So maybe, Emma, we could open up the lines.
Sure, we can try and do that. Can you maybe just ask what the answer what the application is that the community outreach workers use to input, not the EMR, but who's the vendor for the other system? You said there's 2 systems they use.
Yeah, it's not a vendor. We actually created it ourselves. We developed a web. We hired a web development team and they built it. So it's our own. It's called Population Intelligence, PopIntel for short. This is such a unique program, and we had such specific, unique programmatic questions that we wanted answered that we didn't find anything out there that we were happy with.
Got it. And there's 2 new questions that just popped up.
Yeah, so what is the inclusion criteria for your patients? The inclusion criteria is that they have to have had at least 1 non-obstetric related inpatient admission or over 6 ED visits in the last 12 months. But that's just a primary screen. Then what happens is that the outreach worker, they get referrals through a number of ways. Our triage coordinator is milling through these hospital and ED census reports that we get daily, looking for people that, and she can actually drill down on some of those admissions to identify why they were admitted. So for instance, if somebody had an accident with no prior history, she can look into their history and look at sort of what the pattern of utilization has been once she gets notified that they've recently been admitted. And so she weeds through, she has a clinical background, so she weeds through those and will send referrals of people that look like they're good candidates for the program directly to the outreach workers. But they're working as part of a primary care team, so they're not going to outreach to someone unless they have a conversation first with someone on the care team, whether it's a care manager, they can look in the EMR and read notes, or ideally they have a quick 3-minute curbside conversation with a provider just to make sure that the provider agrees it's a good candidate for the program. And then the other big arm is that providers are referring clients. I mean, they know their patients better than any claims system knows their patients. And so they're now, as time goes on, getting really good at identifying appropriate clients. So to get even more specific on that, we're looking for clients who have modifiable psychosocial, social determinants of health risk factors that are complicating their ability to manage their medical conditions. And we're looking for clients who may not be jumping up and down to participate and work with us, but are not actively declining our participation. So if somebody says, I'm not interested, I don't want anything to do with you, we are not going to go running after them, in part because we have plenty of people who need our help that are ready and willing. What we will do is we'll sort of plant seeds with that person as much as we can to let them know that we're here if they change their mind, that we're working closely with their provider team, And then if at any point they feel like they could just use a little help, we're here for them. Sometimes it's, would you be willing to just go out for a cup of coffee and talk about what I might be able to help you with, if they're not just completely slamming the door in our face, a virtual door. And then, you know, there isn't really any other exclusion except violent behavior in the past or current. So any knowledge or documentation of violent behavior, or any active methamphetamine, cocaine are the two drugs that we sort of excluded. Heroin, no. Certainly drug, opiate addiction, alcohol addiction, marijuana. Those, I mean, we wouldn't have anybody to serve if we said anyone who's actively using, you know, illegal substances we won't work with. So it's meth, and cocaine is a little grayer. I mean, that's where we're gonna really look at the history, and you know, we have a lot of safety protocols that they follow. They don't ever meet anybody for the first time at their home, and the ideal place to meet them first is in the clinic. So yeah, I mean, I hope that I've answered that question. I think there was another one. Okay. Do I think that once-a-week huddles are sufficient? Other programs do daily huddles. So once-a-week huddles centrally located are sufficient, but that is not to say that they don't do huddles with their care teams in the clinics on a more frequent basis. So yes, in many of those clinics, they're huddling with the care team members on a daily basis. The weekly huddles that I described is our programmatic community of practice time, where we're actually, as a community program, coming together to build a culture, to create a supportive peer environment, to set standards, to do trainings. So that's our way of bringing everybody together so that they feel like they're a team, a workforce team, versus they're like bicultural individuals. They have a foot in the community of practice health plan program and a foot in the primary care practice. How do I measure health advocate effectiveness on an individual level? Health advocate effectiveness. I would say that we're not necessarily measuring exactly that, although the health status survey that is going out to people upon graduation gets at a lot of it's not just, you know, regular functional health questions. It's more, it asks questions about how has your life changed as a result of this program, and it's both closed-ended and open-ended questions. But we don't have, we don't have a particular scale that we're using to measure advocacy. I think the other thing that we're piloting right now is something called the self-sufficiency matrix that was developed in Snohomish County in the state of Washington, and that's really something that is filled out by the outreach worker on a regular basis with clients, but it measures across many domains of health in very discriminating, it has a very discriminating scale so that we can really watch the progress on a minute basis of people moving through what we think of as moving along a path toward wellness. Yes, we should definitely measure days in the hospital per year, and we are including that in our evaluation this summer. We actually had the data to include it in our interim evaluation, but the evaluation scientist had too much on her plate to finish that portion of it. Do we enroll by phone? Let's see. Do providers receive additional? Oh, that's a great question for providing. So as I mentioned earlier, so the question about how are we incentivizing providers to participate, because it absolutely does take their clinical leadership and commitment to this program to make it successful. So this was This is a part of healthcare reform in the state of Oregon. We received a $17.3 million innovation award from CMS, from CMMI at CMS, and this program is one of 5 interventions funded through that innovation award. As such, we are relying on a lot of volunteerism and commitment to the population and to healthcare reform at this moment, and so there is not any specific incentive for those providers. They are literally participating because they believe in it and because they're seeing the demeanor and outcomes of their patients improve. But that being said, we are building it into our sustainability plan. So as we start to think about how we will pay for this when the grant ends, we know that we will need to incentivize those practices that have a high proportion of these members are participating fully in the program. And so we don't have that answer yet, but I mean, I'm constantly talking to people across the country about different ideas for that, so we will be doing that. Do we enroll by phone, or do we do a site visit to offer enrollment? Once you set up home accept. Yeah, no, we do. The phone calls, we do a lot of phone calling and text messaging, but that happens after we have established a lot of trust and rapport. So engagement happens face-to-face, both in the clinic, but it may start in the clinic, but ideally we're making community visits, and that's how we're getting our enrollment up. Oh, okay, clarification. How do I measure the effectiveness of each of your advocates? Some health advocates are better than others. How do you identify the high performers from poor performing? So when you say health advocate, you're talking about our workforce, which we call community outreach workers. So this is where the team supervisors come into play. So, you know, we have staffed so that each team supervisor has no more than 10 outreach workers, and they are hardly in here at the office. They spend most of their time out in the clinics, going to the huddles within the clinics, watching and observing how our team members interface with the primary care practices, and then they have dashboards. So they have both productivity and caseload measures. They do chart reviews, they look at documentation, they listen, we have a weekly, in addition to our weekly huddle, we have a weekly what's called a case review, and that's where it's on the phone, and so our staff don't have to come into the office to do this. They call into a centralized number, and everyone has to go through their entire caseload in about 5 minutes. And so they're literally, what they're doing is they're talking through what's the goal, what am I doing next for each client. And we learned this from the program in Camden. That's one really, really good way for our supervisors to know whether people are on top of their caseload and are being goal-oriented with the clients. I'm working with a group of young adults who never transitioned to adult care. 16 patients, 773 hospital days in year 1, $5 million in charges. Any experience with this population? No, not with this program. Although we actually have a couple of outreach workers that we hired from, one came from the juvenile justice system, and one came from working with Portland Public School System with really high-risk kids and families. So they individually have experience with young adults, but this program does not serve that population, so I really can't speak to that. That's a tough one, though. Okay, we're almost out of time, but a couple more minutes. On average, how many home visits or phone calls, for each patient? Oh my God, that's a great question. I have that data, but I don't have it on the tip of my tongue. Let's see. What I thought was striking, so what we measure is we measure how many face-to-face encounters, visits, and then how many digital encounters, which is email or texting, and then how many telephone per client, per outreach worker, and then we total it for the program. And if I'm remembering my numbers correctly, but I could always refer back and send somebody an email. Like in the first quarter of the program, we had something like 200 individuals enrolled in the program and over 2,000 touches, and about about 35 to 40% of them were face-to-face. And what we do is we have, because we don't want to burden them with so much documentation, we have them log their digital and telephone encounters once a week. And so then they estimate over the course of the week how many telephone calls did I have with this individual. So it's pretty accurate, but it's not absolutely. We had to balance the documentation burden with the programmatic information that we need. I think what I would say is that I've managed care management programs for years, and our data suggests that this is a very high-touch program, that one individual is getting a ton of touches, particularly in the first month of their engagement with the program. So it's a very high-intensity program. Okay, it's 1:30. Any parting words, Emma?
No, I think that was a great presentation. Thank you so much. And as you know, we recorded the session. It's going to be sent out to everyone by email along with the slides. And I just would ask anybody who's still on the line to complete the poll questions. These are different than the first poll that we started out with. This helps us get a sense for how successful this presentation was and how relevant it was to you.
Okay, thanks so much. Have a good day.
Thanks, everyone. I'll leave this open for just a little bit longer to make sure people have a chance to fill out that poll, and then we'll go ahead and end the WebEx session.